So I gave the kind of title talk of thinking about potential negative consequences of some choices in PBS. I know the conference topic was kind of slightly different, it's about kind of potentially sort of professional humility overall, but I think this fits in terms of either active choices we might have made or some implicit choices, but also that linking up with some idea of sort of professional humility or professional identity or both. So hopefully it'll make sense by the time I get to the end, but this is about some choices, and it's a selective presentation focused on a few things that have been exercising me rather than a kind of comprehensive overview of everything. I'm going to cover four things, and as you'll appreciate a little later, this is a little poem. I'll come to that at the end, but I'm going to talk about trials, concept creep, our behavioral roots, and doing it on the cheap. And just for reference, the little picture on the right there is to let you know that that is old Joe, the clock at the University of Birmingham. The gates are not Hogwarts, but UOB, and that shows old Joe in 1990 and not 1990, in 1900 and in 2025. So it's the university's 125th anniversary, and that clock's been there for a long time. So that's what I'm going to cover, those four issues, not necessarily in that order. They just work in that order because it rhymes a little bit. But I wanted to start with thinking about, to understand what I've got to say about this idea of concept creep, and thinking about our behavioral roots, we need to consider a little bit some history. So effectively where positive behavioral support has come from. And it's come from a kind of long tradition of understanding sort of values and rights in services, but also specific support work and theoretical perspectives and research. So there's a lot of stuff that has fed into positive behavioral support as it might look like today. And on the left-hand side of the diagram, there are some key changes in the provision of services or policy or our understanding of values around people with learning disabilities in particular. All of those feed into positive behavioral support. So there was a significant movement around normalization, or later called social role valorization, about kind of valuing the lives of people with learning disabilities, and if you like, kind of ensuring that they have a typical life like everybody else and have a right to that. And that fits in with the disability and human rights kind of agenda as well, that's clearly fed into how we think about positive behavioral support. And big shifts, especially in many Western countries, that really influenced the development of positive behavioral support and what it looks like, especially as a community-based framework of supporting people, came from large changes around deinstitutionalization. So certainly in the UK, that was the case, and we have very few sort of traditional institutions left, although one might argue that there is a kind of re-institutionalization at some level with some kind of specialist services. But effectively, there was that big deinstitutionalization movement, perhaps from the late 70s, but certainly into the 80s. So a long time ago. So there's a long, long history here of changes in policy and values and our thinking that have fed into positive behavioral support over a long time period. But also what's fed in are the things on the right. So significant amounts of research on behavior change, theory around behavior change, that literature didn't develop to solve the problem, as it were, of challenging behavior, if you like, but was there in the kind of background. It certainly fed into the development of positive behavioral support. And then separately, as well as behavior change theory and research, there was quite a significant element of research around challenging behavior, sort of epidemiology, sort of risk factors, understanding, and thinking about our kind of theoretical understanding of challenging behavior as well. And so all of that very much fed into positive behavioral support. So it didn't just appear from nowhere, and it didn't have its own trajectory that kind of, people decided this needed to be done, and therefore that's what happened. But it kind of grew out of things. It grew out of a lot of history, and that's particularly important to understand, that it grew out of, values and rights, but also behavior change and challenging behavior research as well. That's important to understand. It didn't appear from nowhere, and of course it does keep evolving over time as well. But it is important to understand kind of those historical roots. One of the things then that we need to consider is, okay, that's kind of some of the context of where positive behavioral support come from and what's influenced it over time. But the key question is, well, what is PBS for? Kind of effectively who it was for, or what problem was it meant to address, or why is it as it is in terms of what its focus is. Implicit, although we've tended to make it more explicit in the UK developments around positive behavioural support in recent years in particular, that there is an underlying kind of understanding or model, if you like, or way of thinking about challenging behaviour in particular that really underpins positive behavioural support and helps define what it looks like today. And so that's summarized on this slide, and I'm happy to send people the paper where this came from, so you can have a look at it. But it is also summarized and reproduced as well in the State of the Nation report from 2022 that Nick Gore led. So the whole idea is that we understand challenging behavior in the middle there, is made more likely to occur or is more likely to occur in certain circumstances, and those we might understand as vulnerability factors. So there are biological vulnerability factors for challenging behavior. Having an additional rare syndrome, especially some specific syndromes, make it quite likely that certain types of challenging behavior might be in somebody's repertoire. Having an additional diagnosis of autism as well makes it more likely that individuals will show behaviours that challenges, and we know there are physical health, epilepsy, sensory impairments that feed into the likelihood of challenging behaviour being more likely to occur. So there are biological risk factors, and important to understand that. However, really the bulk of the vulnerability factors that feed into challenging behaviour are psychosocial, environmental. Some of those are about some of the skills that individuals with learning disabilities and others might have. So, lacking communication skills, for example, but then also things like exposure to negative life events or potentially traumatic events, having high levels of stress in the kind of family context if you're thinking about those who live with their families, or maybe stress in support workers if you're thinking about a social care situation. There's clearly also some connection with mental health problems, some association between mental health problems and challenging behavior. When you see one, you're much more likely to see the other. But we also see impoverished social networks, institutionalized accommodation with not much going on, and social economic disadvantage as well. All these are psychosocial, environmental risk factors for challenging behavior. And research seems to suggest that when you think about the whole population of people with learning disabilities, and even when you think about individuals, it won't be necessarily one thing that contributes to them increased likelihood of them displaying some challenging behavior, but there'll be a collection of vulnerability factors. So there's an accumulation of risk that makes challenging behaviors more likely to appear in the first place. Challenging behaviors have impact. I'm going to come to the middle in a minute, but challenging behaviors clearly have impact, which is why we're interested in them. They have some biological impact. They are kind of risky for individuals and others around them. So, challenging behaviors are much more likely, people who display challenging behaviors are much more likely to be prescribed psychotropic medication, even if that's not being used in a therapeutic way. There may be harms to the individual or to other people. And there are psychosocial outcomes, so including that harm to others, but people with challenging behavior are much more likely to be excluded from social and community activities, for example. They're also much more likely to kind of lead on to having mental health problems. So it's not just a vulnerability factor, but challenging behavior might increase vulnerability for later mental health issues. So there's significant impact on people, which is why we're interested in doing something about it. And then the really important area of sort of conceptual, theoretical, and practice work then that's gone on, because the practice and the assessment and understanding of challenging behavior is clearly linked to our sort of conceptual thinking around it, is that there are maintaining processes around challenging behavior that are effectively behavioral processes. So that challenging behaviors might lead to direct pain reduction, for example, or lead to some positive automatic in reinforcement. Sorry, the little spelling error there. But so those are kind of more automatic processes or biological processes, if you like, that might maintain challenging behavior. But we know and we understand when we think about challenging behavior and when we assess challenging behavior for functions and we think about how we're going to change it, a lot of it is about what's going on in the kind of social environment. So other people's kind of reactions and behavior around a person, other things that we know powerfully are involved in the maintaining or maintenance of challenging behavior. So that social environmental factors are really crucial to us thinking about challenging behavior, both in terms of vulnerabilities, their impact, but also those maintaining processes. There are other things going on. Clearly, there is that biological dimension, but as we know, a big part of understanding challenging behavior is those social environmental processes. That leads into, if you've got that kind of relatively explicit understanding of challenging behavior, it leads into positive behavioral support kind of needs to address most of this somehow. And of course, that's where we get to in terms of the sort of latest definitions, if you like, of what the key components at least are of positive behavioral support. So I'm not going to go through all this because I'm hoping that you're all familiar with it and you can read it in detail in the Gore et al. 2022 publication, but just to emphasize in terms of what I've already talked about. So rights and values are clearly right at the center of positive behavioral support, and that comes from that historical perspective, including some historical perspective about inappropriate supports for people with learning disabilities. So too much use or use of, I should say, aversive, restrictive, and abusive practices. So reducing those, getting rid of those, eliminating those is a kind of really important part of PBS. And not just functionally based kind of interventions as a part of PBS. So rights and values are clearly important, and you've seen the history of where all that comes from and why it's significant currently too, still. Unfortunately, we saw, just in the news yesterday, I saw in the ITV news, which probably a lot of you clocked, another abuse scandal. So these things are still going on. So they are still current, relevant, and we need to consider them when we think about PBS, but also other approaches when we support people with learning disabilities. And then basically the theory and evidence base kind of comes from, that long history of behavior change research and challenging behavior, but from that model of understanding of challenging behavior that I was just talking about as well, that underpinning, so biopsychosocial model of behaviors that challenge. So the kind of behavioral roots, if you like, the behavioral concepts, the behavioral methods, the behavioral intervention approaches are a core part of PBS. You can't separate it from PBS because of our underlying understanding of challenging behavior, and also, of course, considering that history of where PBS came from. And then the rest are sort of process strategy issues, but not perhaps so crucial to my argument, but they're important parts of thinking about the broad nature of PBS. And they're really important when it comes to thinking about how we evaluate PBS as a coherent framework or approach as well. So do bear in mind those extra complexities there in terms of process and strategy as we move on to think about trials and evidence a little bit later. But hopefully you can see why some of the key features of PBS are in the kind of conceptualization or definition of positive behavioral support and why it includes multiple components, where all that comes from. It's really crucial. So that's PBS, and we've kind of looked at kind of what it's for. So I think that provides enough introduction for me to move into what essentially the core of the presentation is about, which is some of those choices that I identified at the beginning. So let's focus on some of those choices that I suggested are being made. Either they are, if you like, acts of commission that we've kind of actively made some choices and changes, and sometimes they're acts of omission, things that we've decided we're not effectively going to kind of make decisions about or make choices about. But in either case, they're kind of choices. So let's start with the idea of concept creep. So this concept creep comes from thinking mostly in psychology, and the phrase was kind of coined by Haslam. And there's two types, he argues, of concept creep. So one is horizontal, where sort of concepts extend outwards to capture qualitatively new phenomena. And he does use a number of examples in this paper that I'm referring to. So one of which, for example, is trauma. So in terms of horizontal creep, then trauma had a kind of very particular meaning to start with in terms of its first development and understanding around people's experience in war situations, especially the First World War, or at least after that, in conceptualizing what had been happening. And it's kind of extended out to capture, response to other sort of phenomena, other events, other types of exposure to negative life events of various kinds, for example. So horizontal creep is that sort of a concept extends horizontally outwards from left to right, if you like, in terms of what it captures and what it means. So it generates a broader meaning. And vertical concepts creep, sorry, can't get good at this, is about severity. So the concept extends upwards or downwards to capture qualitatively, especially downwards, less extreme phenomena. So as I mentioned, trauma, let's follow the example of that. So initially started thinking about kind of war situations, soldiers being exposed to kind of horrific, war situations, and now trauma does, seem like qualitatively less extreme phenomena will be captured in that kind of concept of trauma as well. So it's not as severe as perhaps initially defined, but it's extended downwards in terms of what it will cover. And Haslam uses other examples like bullying as well, and also mental health disorder. So mental health sort of psychiatric disorder, as it were, sort of started off kind of quite clearly defined, but has potentially captured, moved out a bit more horizontally and also vertically in terms of what it captures. So I wanted to kind of think about, well, is there evidence of, or is there some kind of concept creep in relation to positive behavioral support? And I wonder if there are kind of three areas where there may have been such deliberate or non-deliberate kind of creep around PBS. So the first of those I know is a little controversial, but I'm just going to mention it briefly, perhaps, is the potential that we start to claim application of positive behavioral support to other populations other than for those where the whole idea, the whole concept, the kind of whole strategies were originally developed. So I've kept referring to people with learning disabilities throughout the beginning of the talk, you might have noticed. So, that's where the kind of history of the research and the kind of values work and services changes all fed into PBS in the first place. So the original kind of long-term development of PBS and showing where it's got to today has come from that background of working with people with learning disabilities with challenging behavior. Now, PBS is made up of lots of principles and ideas as well. And so I do agree that many of those core principles could be applied to other populations who have behavioral challenges, maybe not quite exactly the same always as those we see for often for people with learning disabilities, but they might be other things. And so the ideas around PBS probably ought to be able to be used with and used successfully with different population groups. But my argument is it's taken so much history and evolution and development work to get PBS to this where it is today in relation to people with learning disabilities that you can't do a really rapid, I think, application and thinking about PBS to other populations without a little bit of effort and a little bit of work, because you have to be mindful of the fact that there is that long history and that long development work that's happened. And so um, we need some modeling, some rigorous modeling, some understanding of in what ways might PBS apply to this population. What are we focused on? How are they involved in helping to define that? What sort of are the methods in terms of assessment and intervention that would be a better match for this population in this context? So that thinking really needs to be go on, and practice needs to be developed alongside, and things need to be evaluated, tested in various ways as well, before I think we can be really confident that we can say we can apply PBS successfully to other populations. I think we can make that argument with people with learning disabilities and behaviours that challenge because of all the evidence and the history. But I think we're still in a position where we might need to think about that much more carefully in relation to other populations. And I recognize people perhaps maybe disagree with how I've described that. So there is claiming application to other populations that might be a form of creep if it's without kind of strong basis to and robust basis to it. The second way in which perhaps there's been some PBS creep is sort of moving beyond kind of challenging behavior as sort of classically defined as well. And then thirdly, and I'm going to touch on each of these in a little bit more detail in the following slides, encompassing other interventions and approaches that are not positive behavioral support as well. So there's creep in terms of beyond challenging behavior, and creep using the label at least to refer and trying to bring in other approaches that are not PBS. So let's just have a quick look at challenging behavior, because positive behavioral support was developed as if you like, an answer in part to challenging behavior that people with learning disabilities display. So it's important for us to be clear that challenging behavior does have a very specific definition and meaning over time, and that's been used to inform research and to look at research in terms of epidemiology. And so that this definition, even though it's kind of slightly messy and has lots of components to it, as I'm sure you are aware and are used to working with, it is a part of the nature of PBS, if you like. So there's the Emerson definition there, but it's important that to identify clearly, there's three parts to it. There's a behavior, there's the behavior, there's what somebody is doing. That behavior has to be severe, frequent, or long lasting in some way, and that behavior leads to something, and it has to lead to a harmful or negative outcome. Harm to self or others, results in abuse by other people, restricts participation in everyday life, leads to exclusion. A behavior is only challenging if all those three conditions are met. That's the nature of Emerson's definition. So a behavior is only challenging if it's severe, long-lasting, or frequent enough to, and does lead to, negative outcomes. So any other behaviors that we're interested in applying PBS to that do not meet that definition, probably that is some creep, some concept creep in relation to PBS, moving beyond its original kind of focus of behaviors and behavior change. So that's one thing to kind of bear in mind and to think about in terms of choices that might be being made, anything beyond that original intention. But there's also PBS creep, I think, in using the term PBS or some version of it to define or cover other intervention approaches. Whoops, sorry, I've gone the wrong way. And if you've read the Gore et al. Paper in 22, you'll have seen this kind of attempt to kind of classify different intervention approaches, which I think is helpful because it does kind of clarify what positive behavioral support is in juxtaposition to what other potentially some related intervention approaches are. So the idea, of course, is that we're used to thinking about the kind of core, the dual goal of positive behavior support being behaviors that challenge reduction, but also increase in skills, opportunities, positive environments that support life quality. So positive behavioral support has that dual focus. Those two things have to come together or it's not PBS. And there are other approaches that don't necessarily focus on reducing behaviors that challenge actively, although may have an impact on reducing challenging behavior because they're about increasing skills, opportunities, environments, positive environments. So things like positive person-centered supports, constructional behavioral approaches like precision teaching to teach people skills, supported communication development is really important, and perhaps self-advocacy, stigma reduction, deinstitutionalization, those sorts of things are not necessarily focused on reducing challenging behavior, but they are about improving quality of life. So they're all not PBS, might be related, but we can't use PBS to describe them, just as we wouldn't want to use PBS to describe aversive or other behavior change processes that including biological ones that and restrictive practices that might try to reduce challenging behavior but have no interest, if you like, in increasing skills, opportunities, making positive environment change. So those things are not PBS either. And also, things that do neither, don't try and reduce challenging behavior and don't have a focus to increase quality of life, are the things that we're seeing kind of scandals about, I guess, in the media. So there are some things there, and active support might be another example where there's absolutely potential impact on challenging behavior, but its main focus is improving quality of life. But active support is not positive behavioral support. Positive behavioral support sits in a unique place. So there's creep in terms of if we use PBS to describe other intervention approaches, then that's an element of creep, yeah, because PBS actually has quite a specific meaning. And there's even some stuff that people describe as positive behavioral support, but I think there's a question over whether it is positive behavioral support or in what way it is. And I'm going to be a little kind of controversial about my first point here, because many of you will be aware of Peter McGill's trial, where effectively the intervention was to really improve the kind of quality of social care service delivery in a big service provider. That was the intervention. And all participants continue to receive positive behavioral support as usual in whichever arm of two arms of the randomized trial they were involved in. So everybody received PBS as usual support. And then one group in certain kind of community-based homes, the people in those homes received this sort of social care improvement kind of intervention. But actually it was called system-wide positive behavioral support. And I'm not quite sure that that's true. I suppose it is in the sense that if we think about what PBS does, there was PBS going on here, whatever that support as usual PBS was, and then there was that environmental enhancement element to it, that system-wide environment quality of support enhancement going on. So you kind of might say, well, that package is system-wide PBS. But actually the specific intervention that was developed and tested here was an element of PBS. It wasn't kind of full PBS, if you like. But anyway, the combination of PBS support with that system-wide, quality of life and quality of support intervention led to better outcomes for people in that kind of second group in terms of reductions in challenging behavior. Although actually, interestingly, no difference in terms of quality of life improvements, which is kind of interesting. But anyway, certainly reduction in challenging behavior. So some things, even though we traditionally think about them as PBS, we might just need to be careful about which are they meeting all the kind of components of PBS? Is this a holistic PBS approach, or is it a part of? And a part of is clearly also there's some strong evidence from meta-analyses, for example, have been conducted on those sort of core behavioral technologies, those behavior change technologies around challenging behavior. We've got very strong evidence that they're pretty effective at changing challenging behavior. But of course, those behavior change technologies are only one part of PBS. So it's only one of the components, is that sort of underpinning kind of behavioral methods and behavior change, if you like. So that without all the other bits of PBS is not PBS. So this is evidence only for an element of positive behavioral support. These two studies, I would argue, even though they're a randomized trial and a meta-analysis, they're not really evidence necessarily for PBS as a whole. So that started to link us into this discussion also about sort of evidence base and trials. Sort of shifting from that, are we being clear about what PBS is covering as a concept and what is maybe a part of PBS but isn't fully PBS? And then I've given you some examples here that are sort of, a trial, which moves us into thinking about evidence. So those who are proponents of positive behavioral support and supporters of positive behavioral support have not really always been the best at getting involved in developing the gold standard of evidence as as internationally, I suppose, kind of agreed and defined. And that gold standard is clearly randomized control trials. Now, there's one example here of somebody who is a PBS proponent, Peter McGill, leading a randomized trial that is kind of very a core part of PBS, if you like. But in general, we've not been very good at a community engaging in that kind of gold standard evidence development. Some of the arguments for that have been, well, PBS is too complicated, you can't test it in a randomized controlled trial, which I don't agree with, because there are lots of complex interventions that people have tested in randomized controlled trials. Some of the argument goes, well, that's not the sort of traditional behavioral way of generating evidence. We do single case experimental designs. Well, yes, you kind of do, but actually using single case experimental designs to test a very complex, intervention with lots of different components like PBS is not really a good match either. So you might have those sort of specific components, like the sorts of things that were covered in this meta-analysis that I've mentioned on this slide, but you're not going to be evaluating the whole of PBS. And actually, perhaps a randomized trial is a better way of testing a complex intervention like PBS. You allocate people to receiving that complex intervention versus receiving something else. So what do the trials tell us that other people have done who've not necessarily been proponents of PBS, and have they been any good? Well, a psychiatrist in the UK, Angela Hasiotis, has led two really important PBS trials, and I'm going to describe why they might be important and come to a conclusion about them in a moment. But hopefully you're aware of both of them. You're probably aware of one of them because it's more recent. There was a little bit of controversy about it in terms of what it showed. But the first one you might not be necessarily that familiar with. So the first trial that Angela did was actually in the sort of early-ish to mid 2000s. And what she did was take a specialist challenging behavior team, which effectively was probably delivering at that time what would have been kind of PBS best practice in an NHS kind of context. So individuals with challenging behavior and learning disability were randomized to receive care from that team and whatever usual other supports were available, or to just receive other usual supports and not be randomly allocated to that team. And what she found in the trial of 63 adults was that those who were referred to the specialist challenging behavior team had a greater reduction in challenging behavior at follow-up, and there was a trend for lower overall costs as well in that group. And at 2-year follow-up, those challenging behavior outcomes were maintained, but there was no difference in costs of services delivered to the two groups over that 2-year period. So initially, it was cheaper to refer people to a specialist team in terms of the rest of the services they received, and their challenging behavior reduced, and certainly over long-term time or 2-year time follow-up, challenging behavior was still reduced. So that seemed to be quite an effective intervention. Cost no more and potentially less to allocate people to a specialist team and receive intervention, and that specialist team intervention was more effective than whatever was going on as usual. Now, there were actually no data collected on what the nature of the PBS support looked like in either arms of that trial, so it's still a bit unclear exactly what was going on and whether the intervention might have met all the criteria for, as we define PBS now, but it's an interesting study nonetheless. And then the second study that Angela and colleagues did, which was much later, was really to kind of test this idea, I guess, that is probably still being done now, and I'll come back to that in a moment, but where one way of kind of getting PBS out there to individuals with challenging behavior is obviously to train people in some PBS skills, ideas, concepts, knowledge, and to support them in developing interventions with individuals, and hopefully their skills then mean that they could also take on new cases and be effective at delivering PBS-based support to those. So this sort of idea of sort of initial training, and that training of skills and knowledge will then enable people to deliver high quality support that's PBS based, is a fairly typical way of delivering PBS, isn't it? And so Angela and her team kind of tested that out. They took 23 community-based teams in the NHS and randomized the teams to either receive staff training in PBS or to not receive that training. The PBS training was kind of reasonably typical. It was sort of 6 days of training, delivered certainly by PBS experts, and there was some ongoing mentoring support offered. Now, whether that was always taken up or delivered is not quite clear, and in fact, it probably wasn't. There was no data collected again on what support as usual was. So in the community teams, that were recruited into the trial, they may have been delivering aspects of PBS already, or staff may have had PBS skills. And so in both arms of the study, there may have been a fair bit of, in quotes, PBS going on. But in any case, the PBS training was definitely an added element during the time of the trial. Now, there were fidelity checks completed on the PBS plans that staff developed around individuals that they were supporting out of the 246 adults with learning disability and challenging behaviour that were enrolled into the study. All of the PBS plans that were developed, though, were rated independently as inadequate. So it's not just poor, but inadequate. So pretty much the lowest level that you could get, rubbish. And the outcomes were that for the two groups in the trial, those services where the training had gone in and those where it hadn't, there were no group differences in terms of outcomes for challenging behaviour, and no secondary outcomes showed difference either. So any of the quality of life or mental health or other outcomes that were measured, there was no difference at all. Now, of course, people who perhaps come from two different perspectives, either are anti-PBS or may not take the time to look very carefully at individual research studies, certainly have concluded that this means PBS is ineffective. But what it really means, I think, in terms of these two studies together, is that one way of delivering PBS through a specialist team where everyone is kind of specialist and trained and focused around working with people with challenging behavior, you can generate some positive outcomes. If you just train people in PBS, probably they don't get access, or they don't access ongoing mentoring support to really kind of reinforce those skills, then that doesn't appear to be ineffective. So just training without other sort of infrastructure systems change is probably not going to be effective. It doesn't tell us PBS is not effective. These tell us about the ways of delivering PBS being more effective or less effective. And actually, there are other studies a bit like that. One of those is the one that we've already talked about, Peter McGill's study. So if you add in high quality social care, quality of life developments in community-based homes, and add that onto standard PBS support, which is effectively, as we discussed, the sort of design that Peter and colleagues had used, then that's more effective than just running PBS alone. So a more effective version of PBS is to take PBS and add that real emphasis around quality of life, service, quality environment, capable environments, if you like, positive environment development. That makes the intervention more effective. That's great to know. And also there's some strong evidence from randomized trials that adding in other components might enhance the effectiveness of positive behavioral support. So most of the work is no, that's not true. I'll start the sentence again. So two examples. So first is Mark Duran's family-based positive behavior support, where they work with individual families of young children. And Mark ran a study where he did a randomized control trial, randomizing families into just family-based positive behavior support, or positive behavior support with effectively a sort of a CBT type stress reduction program alongside for the parents. So he called it parental optimism training, but basically it was kind of like stress reduction, well-being support for the parents at the same time. And if you combined the family-based PBS with the stress reduction work, if you like, then that was a more effective intervention. It delivered better, stronger reductions in challenging behavior at follow-up. And this was done very tightly. They did video recordings to fidelity checks. Around 2/3 of both groups completed the intervention. So that's quite a high completion rate for if you're thinking about trials that are doing something very applied. So it was all done very well and demonstrated that you add that component in of sort of supporting care as well-being as well, then that seems to enhance the effectiveness of a PBS intervention. And if you go back to our model of challenging behavior and some of those maintaining processes, one of the things that's driving the way that other people respond, of course, is their sort of emotional entanglement, if you like, in challenging behavior. challenging behavior can be quite stressful to have to experience, to deal with, especially over time. And so you can imagine that people are going to be much more effective in their behavioral responses if you support those sort of emotionally aversive sort of elements of life with somebody with challenging behavior. So you can kind of see the conceptual sense in, you add in stress reduction to PBS, it helps people be more effective in their delivery of PBS, it makes PBS more effective. And exactly the same sort of evidence base also applies to Nirbe Singh's mindfulness-based positive behavior support. And he's done a number of trials now, most with staff and with parents, showing that if you run a sort of standard, PBS individual intervention approach around those working with a child or adult, and you add in mindfulness-based stress reduction to that, you get more positive outcomes for the mindfulness-based PBS intervention than you do for PBS alone. So again, follows the same argument. So basically, we can generate evidence, and people who are more interested in PBS have tended to do it this way, which is how do we enhance how PBS works rather than asking the question of whether it works. And that's probably the direction we need to move in, given that, especially in the UK, we're in a fortunate position that I know there are still kind of arguments going on, but actually overall, in terms of national guidance, PBS is in a fairly positive place, that people are expected to be kind of delivering PBS. Commissioners are expecting to be commissioning PBS support services. So our questions in research and evidence and running trials and generating high quality evidence perhaps should be more about how we make PBS more effective than whether PBS works. The need for that has probably moved on. The other kind of evidence that's important to develop, so this isn't just about randomized trials, although those of you've heard me speak before probably know that clearly I think that's important. But actually the evidence base can be developed in terms of evaluating in as robust way as we can existing practice that's PBS based. I'm going to use the example, because I was involved in it, but of Darren Bowring's service in Jersey, that he carried out some evaluation included in his PhD thesis. And this is kind of, this is a typical PBS service in Jersey, where people are children and adults, it's a lifespan thing, and also people with intellectual disability and people with autism are referred in terms of their challenging behavior. And the service responds, with some initial assessment, basically. And sometimes that initial assessment might be that there is no need to go on to a kind of more detailed functional assessment and interventions based on that functional assessment, but other things can, after initial assessment, are obvious that need changing. And so the PBS service doesn't just do full-blown PBS all the time, but is making assessments about what changes need to be made, sort of having in mind, I guess, probably that underlying model of challenging behavior, if you like. So what are the things that are influencing this person's challenging behavior, and what do we need to do to change them? But so sometimes the interventions and supports are kind of relatively short, and sometimes they're long. Sometimes people need complex functional assessment, intervention plans, developing individualized PBS plans that are monitored and changed over time until you see improvements. And I'm guessing that for those of you who work in sort of PBS specialist services, you work in a similar way. Sometimes you need a relatively light touch intervention, actually, and sometimes you need a much more kind of complex and long-term one. Or maybe you work in services that only do the complex long-term interventions, but you've got kind of referral criteria and initial assessment criteria, or that mean that you kind of select out the cases that need that. Anyway, Darren's model was kind of more mixed. So they knew what model they were delivering, although in this evaluation work, which would be fairly typical for evaluating everyday practice, they didn't collect lots of fidelity data to demonstrate that PBS was being delivered. But anyway, at follow-up, which was at the close of intervention rather than after a fixed period as you would do in a trial. So that reflects, how much intervention was going on, somewhere between 15 and 160 weeks. So at the close of intervention, there were larger positive effect size changes in quality of life, and also large effect size reductions in challenging behaviour. And they collected satisfaction data with, it's effectively for social validity, if you like, from carers of individuals who referred to the service as well, and they had very positive ratings. So these sorts of studies are really crucial too, because it's important to still keep evaluating still keep developing the evidence base for an intervention, even if it's used quite a bit in practice, because we want to demonstrate, well, what are the effective ways of delivering it? And that doesn't always need a randomized trial, but does need kind of robust evaluation and thought about, is this model delivering some good outcomes? And of course, if it's not delivering great outcomes, how should we change it to make it more effective? So we should be getting more involved in evaluation studies and more involved in writing up practice and evaluations of practice as well. I just wanted to mention Harry Potter, just to make sure you're all concentrating. So following that, think about the evidence. I think there's a nice story from especially those more significant randomized trials or larger service evaluations. So they tell us what we might do in relation, we should do, or we probably should be doing in relation to PBS, and what we shouldn't be doing. So I think the evidence tells us, do deliver PBS through a specialist team or service of skilled people, and that might cost no more than usual supports when in the end you look at what services people with challenging behaviour draw on. Even though it might cost money to deliver a specialist service, it's still perhaps cheaper or no more expensive overall for them to receive that than it is for them to carry on being supported as usual and not receive active intervention. Because we see that typical delivery of PBS models by specialist teams also leads to improvements in challenging behaviour and also quality of life. So that specialist team model is kind of a solid thing in terms of the evidence base. What I think the evidence tells us that we should not do is deliver short PBS training courses for staff in typical community services without thinking about what else needs to go on around that to make that training embed, to make sure skills develop, and that people become effective and the whole system changes so that the delivery of PBS becomes high quality and drives down challenging behaviour and up quality of life. Just train and leave is definitely not worthwhile, it seems, from Angela's trial. And we should be using as well as the team model overall, we should be using versions of PBS that have theoretically supported additions to them that are designed to potentially improve effectiveness and PBS delivery. For example, combined with well-being elements for staff and family members, that seems to make PBS kind of more effective, or adding that overall sort of quality of life service improvement kind of model that Peter McGill worked with. And to reflect a little bit more on some of the things I was saying about kind of evidence, I don't think there are excuses given that we know PBS is a complex framework with at least those 12 components as we've identified them or defined them recently. There's no excuse for not evaluating PBS and PBS in full, but it's really important, I think, when we're thinking about individual evaluation studies that claim to be about positive behaviour support, that we think very carefully about what components of PBS are actually involved in this intervention. Does it involve all 12 elements, or is it something else that's kind of a slimmed down version, or a version that focuses on certain things in a certain context that might actually be useful, but is not the kind of full-blown PBS model? What is being evaluated? And it's also important now that we think about any comparisons or controls that we have in a research context. PBS is so prevalent, if you like, out there in terms of ideas, some of the elements of it, some of the skills that people will have developed, that there's almost definitely going to be elements of PBS in almost any support as usual nowadays. So we do need to very clearly identify what's going on in any control or comparison condition in any research. Now, when we're measuring the effectiveness or outcomes of PBS, fidelity to PBS is really significant. Now, one of the ways to think about that is just looking for evidence about whether each of those 12 components is represented. But of course, a really core part of it, and one of perhaps slightly easier things to do, is to say, well, at the core of most kind of PBS interventions is going to be a behaviour support plan. And of course, there are then tools that enable you to evaluate the quality of those, including the new behaviour support plan content appraisal tool, the BSP CAT, which I hope some of you have heard about. And if you've not, go to the PBS Academy website. It's just been put up there and you can download the BSP CAT and the associated manual about how to use it. And PBS interventions vary according to the context and the purpose and potentially the population, as well, I was touching on earlier. So if you're supporting families, that will look different than if you're supporting adults in social care. It'll look different to how you support people in a health service context in the community. So each of those looks slightly different in terms of how it's delivered and conceptualized. And we need to kind of be aware of that PBS doesn't look exactly the same. It includes those definitional components, but it doesn't look exactly the same in every context, and it shouldn't. But each delivery of PBS in a different way requires an explicit sort of theoretical, conceptual development, perhaps a logic model to show you what it looks like. And it certainly involves, if you're thinking about using PBS in a new way, in a new context, co-production is really important with those who are going to be stakeholders in it, be they professionals, families, and certainly the population for whom the intervention is designed. So that might be people with learning disabilities. And if you were thinking about moving into autism populations, it would be autistic people as well. And those new ways of delivering and conceptualizing PBS also need to be tested. We can't make assumptions that they'll work effectively in the same way as the existing evidence base is telling us about the ways that PBS with people with learning disabilities might work. There's also a lack of robust, what we call process evaluations of PBS intervention. So this is not just about the outcomes that you see, but also what's going on in the intervention. So some of that is about, the fidelity of delivery. Are the behaviour support plans any good? Do people develop their skills if you deliver training to them, and do you measure that? But also more qualitative work, trying to understand, well, what was effective, what worked well, what were some of the barriers, what were some of the problems, and all that evidence is important, especially in feeding into how we deliver PBS on a day-to-day basis. And I think, as I've illustrated, hopefully, no single existing study out there in the literature anywhere can be used to answer the question of whether positive behavioural support is effective. No individual study. We have to look at the accumulation of evidence. And that evidence can really, at the moment, in my argument, only really tell us some of the better ways or best ways of doing PBS rather than whether PBS works. And I'm going to end there with just coming back to my poetry. So I didn't do them in this order, but our little poem is to remind us of the sort of things I've tried to cover today in terms of choices and, whether deliberate or not, and thinking about some of the benefits and also limitations of some of those choices is trials, concept creep, behavioural roots, and doing it on the cheap.
Richard, thank you. Absolutely brilliant. We've had a couple of questions come in.
Okay.
So I'll get to those if you're happy to take some.
Yeah, happy to.
And I'll have a couple as always.
I'm not going to answer yours.
Yeah, don't blame you, Richard. Yeah. Yeah. One of the questions came in from our friend Jed. And I think this is related to the 2018 Hastings paper that you referenced, Richard. And essentially, I think I think this question is really aimed at can you implement PBS as part of your job? And I think some of the participants that were referenced in the 2018 Hastings study were perhaps nurses that had been asked to undertake the PBS training, or perhaps you're a ward manager, for example. So I think Jed's question is about, can this PBS role be a bolt on to other people's jobs, or do we need people that are functioning as PBS practitioners solely within services? Yeah, I wonder what your thoughts are on that.
That's a really excellent question, Jed. Thank you for that. Yeah, very much an important question, and I'll answer it, I think, in a number of ways. So I think if you think about PBS's overall sort of framework, and in particular the systems element, then actually what we should be thinking about is sort of what PBS skills and competencies are needed by different participants in the system, if you like. So I think there'll be a mix of roles, and that's represented as well in our thinking around, what are positive behavior support competencies. So there may be a base level of understanding of PBS that everyone in the system supporting those who are going to be at risk of challenging behavior are going to need. So they might have a role, they will have a role in kind of supporting PBS as a sort of systemic intervention, but they won't be the specialists. So they'll be doing other things. They'll be running care, or they'll be doing other things. And that's fine. So there is clearly in the PBS system, if you like, a role for those whose job is not fully PBS. But equally, I think you need those whose living and breathing is PBS, and they are the kind of trained to a much higher level in their PBS knowledge and competencies. And in a PBS system, in a service system, I think you need those specialist roles. When it comes to thinking about that in relation to the Angela Hasiotis trial, I think that's kind of what prompted the question. My understanding of that is what Jed summarised. I haven't looked at what you summarised with Jed's question, Paddy, which is, it was added into people's roles. So they had plenty of other things to be getting on with. They received some training. There was mentoring support available, but of course there are other priorities that people had to address. So that was a barrier, or acted against probably the training being useful or effective in that context. And it might be why training of that sort may be quite difficult to make effective, where people are taking on some new skills, but they're not supported to deliver that. And actually, this is not a PBS specific thing. The rest of the evidence out there, when you think about other intervention approaches, is very similar. So if for example, you think about people who are trained in cognitive behavior therapy skills, there is an element of, awareness around CBT, models of understanding around mental health, and some basic skills are really useful for anyone in the mental health system, but they have other roles. However, we still need the expert CBT therapists who will do the kind of one-to-one therapy with people. And certainly what's experienced, I think, in a number of mental health services is if you train people up in CBT skills, for example, you really want them, because they're the most highly skilled, to be doing the individual evidence-based therapy and not other roles. Because if they're doing other roles, their skills are not being utilized overall. So the investment in their skills is perhaps not made most use of. But also they get, again, like with this discussion around the adding into the roles of the staff in the Hasiotis trial, if they're doing other things, those things become priorities at different points. So in mental health services, that might be, there's massive long waiting lists, or there's very high risk people who are kind of suicide risk, self-harm risk, for example, and you've got to deal with that first, because clearly, threat to life is a really important thing to do. And so you will never get, even if people are highly trained, if you've got roles where they're more generic and they have a bit of CBT time, they're never going to get around to using those skills. So I think it's exactly the same for PBS, probably, in my view. And I think there's enough evidence out there in other circumstances that the best way to get most effective impact from, developing people's skills, training them in a particular intervention approach, is that most of their time is delivering that. And that's reflected in the PBS or challenging behavior expert team sort of model as well, isn't it? Where that's what all that people are doing. They develop real expertise and they develop systems and everything. That's what they're doing. Other supports are going on as usual as well, but they're delivered by other people. And that appears to be an effective way to kind of generate outcomes for people with challenging behavior.
Yeah, thanks, Richard. Oh, yeah, well answered. And I think it really dovetails in with a lot of the conversations that have been going on today about ensuring kind of senior management buy-in you know, people are adopting and embracing and implementing positive behavior support. And certainly we've advocated in the past when people have spoken about that kind of approach, maybe second somebody into a position for a period of time, give them a good go at being able to do this kind of full on, because yeah, you find people default back to where they're most comfortable very often, or where the people are shouting loudest. So yeah, I think considering kind of secondments, if that is going on for somebody, because it's really hard to do this when you've got other stuff going on. It's hard enough to do it full time,
Yeah.
let alone do it when you've got other stuff going on, I think.
And
Yeah,
I
brilliant.
mean, there's other areas of work that in our field where the evidence is the same. I'm sorry to make the same point again, but in thinking about transition to adulthood, it appears that the most effective way to deliver that is people who have that transition role as the only thing that they do, not just added into a generic role. They never get round to it.
Yeah,
And but that's not the way necessarily that services are provided now. But certainly the stronger evidence is for those who have a specialist role.
yeah, yeah. Richard, I just need to say the two keywords for everybody again. These things often get missed a little bit. So the keywords are Harry, so that's a capital H, lowercase ARRY, and Hogwarts with a capital H. So for everyone, those are your two keywords, Harry and Hogwarts with capital H. All right. Thanks all.
They
Um,
were, and I remembered them.
You did. You did. Thanks, Richard. Yeah. In fact, very clear. But yeah, I think people were so engaged with what you were saying. I think they've completely missed it. Scott's got a question for us, Richard. So, this idea of concept creep is a good one.
Mm.
But
Mm.
how do you counteract motivators that include A, business interests for these PBS companies to take on complex people beyond their evidence base, and B, services who struggle, so are happy to outsource their most complex people to these businesses?
I think that's a really interesting one, because you're right. There are different contingencies working here, and that's partly why I said I kind of understand where some people are kind of coming from here. But I suppose I'd hope that those who kind of are running businesses around PBS and therefore need to survive, they need to bring in income, they need to develop new business. There is um, a shared interest, I think, in doing that and being developing concepts, developing ideas, describing models, evaluating models clearly as well. So I think in my in those definitions of PBS, some of the definitional components are about kind of monitoring, using data, gathering data, kind of clearly describing things. So we're used to, when we think about behavioral approaches, clearly define the behavior, so we kind of have all those kind of ways of thinking and skills. And so I would hope that there's a way to kind of combine those. So there's an imperative to, share skills and share things that might be useful to improve people's lives.
Mm,
All this is kind of reflected in kind of shared values, which is part of PBS. So I think if people are signing up to those values, signing up to kind of the core processes and systems aspects of PBS as well, then there is a way to bring everything together, which I think is, be very, in my view, would be transparent if you're moving in with a new population or with a new client with a new sort of problem. You think, well, actually, some of the ideas from PBS might be something that could be
mm,
useful in this context. But be transparent about it. Say, look, this is where things come from. This is how we're going to think about it. Now, to make this work, we think there are some concepts, ideas here that will help us in this situation. What we'd like to do is effectively work together to work out what that looks like. We'll explore, we'll kind of gather some data, we'll see what works, and we'll be clear about what that looks like in the end, and
mm,
perhaps share that as well and say, well, this is how we develop this. We're not saying, you know, what you need is PBS and we're just kind of going to get on with that and not talk to you about it anymore. It's the kind of, yeah, okay, let's be transparent that we don't have the direct evidence base to draw on here,
mm,
but we do have this kind of tradition, this way of thinking, these methods, this understanding. Let's work together and apply it in this kind of context. I think there is that way of bringing together all those things if everyone signed up to the same values and agrees on the kind of core definition of PBS, and we know when we're stepping a little out from it, and we can be very clear and transparent about when we're doing that. And it's probably very appropriate to do that
mm.
because
Yeah.
because at the moment PBS practice and definitions and evidence doesn't cover everything that we think it may be useful for.
It's a great point, Michelle. I think it dovetails in with the final comment that's just come in from Nathan, and similar to conversations you and I have had fairly recently, Richard, about Nathan's point here is perhaps we also need to get better at feeding practice evidence back into the literature base. Where good practice is happening, that is expanding the scope of PBS. This should be part of evaluating and potentially creating that evidence base. It sounds like something you could have said, Richard.
I would absolutely agree. And obviously, I think as well that there's still that role for ongoing sort of tight, applied research as well. But you're absolutely right that, that nothing develops in kind of practice when we think about implementing things we're fairly confident about in terms of their evidence without that practice-based evidence feeding back. So that might be in, as we've just been talking about, in extending into slightly new applications. That's important, but it's even the sort of almost day-to-day interpretation and understanding of delivering typical PBS. There are a number of organizations that are specializing in delivering PBS, training others in PBS, or the mix of those things, and they quite often have a slightly different emphasis in terms of the context they're working in terms of, well, what parts are they using and what ways have they contextualized that? What's going to be a good contextual fix? Because obviously that's a part of thinking, of PBS thinking anyway. But describing that really clearly is sometimes a challenge for people. That they know they're doing something slightly different, but it's hard to find a space, I know, to kind of sit down and, well, let's describe really clearly what we're doing, where it maps onto existing concepts and aspects of definition, where we're doing something that's slightly different, and holistically, how does that fit together, and how is it meant to work? How are we envisaging that what we're doing that is slightly different or slightly in different interpretation of overall PBS, say, how are we expecting that to work? So what's the logic of the intervention? How are we expecting it to work? And then you can evaluate, or is it working in the way that we expected? So sometimes that's in terms of outcomes, but sometimes that's in terms of talking to people about their experience of the intervention or support. What's their experience of the key things that they found valuable, or that really help shift them on in terms of quality life improvements or reduce challenging behavior. And that should feed back into, well, we thought it should work like this. What people are telling us is, it does work like this, great. Or what people are telling us is, actually, some of these things are the most important things in terms of what they're picking up and finding valuable. We feed that back into our concept and logic about how we think what we're doing is working. So we use data and evidence, and it doesn't have to be hard data all the time. Sometimes it's the conversations with people about what they've just experienced, what worked, what didn't, and you feedback that constantly into kind of developing your model and thinking. And so there's that ongoing quality improvement, if you like, which is really crucial, I think, and getting to the stage where you're happy to describe that either in written form or in presentations, and share that with others as a sort of, here's our thinking and here's the sort of evidence we've got that we think supports that way of thinking. So that's the practice-based evidence out there. And yeah, you've got to share it. Otherwise, nobody else picks up on it. Nobody learns from it.
Well, Richard, that's perfect. That allows me to segue really lovely into starting to close out. So I think I just want to extend our huge thanks to you again for coming to join us. Brilliant keynote speech. Thank you so much.